In this episode of Derm Weekly, Dr. Candrice Heath discusses various health disparities that have been brought to light by COVID-19. Welcome to episode 90 of Derm Weekly. I am Nick Andrews. In the news this week, a low threshold to biopsy atypical lesions may identify melanoma early, and our COVID-19 update, a hospital at home. And in peer-to-peer this week, Dr. Heath welcomes Dr. Susan Taylor and Dr. Lynn McKinley-Grant to talk about dermatologists and how they can help reduce care barriers among skin of color population in COVID-19. The peer-to-peer portion of the show will be coming up after the news. Our top story today, having a low threshold to biopsy atypical pigmented lesions on the vulva may identify melanoma early. This is according to a lecture at the International Society for the Study of Vulvovaginal Disease. The mnemonic ABCDE covers the characteristics of melanoma, of course. Those are asymmetry, border, irregular, coloring, uneven, diameter, greater than 7 millimeters, and evolution over time. When a lesion is biopsied because of concerns about melanoma, the goal is to remove the whole lesion at once. That's according to Dr. Melissa Mausker, who presented the lecture. Dr. Mausker is an assistant professor of dermatology and OB-GYN at the University of Texas Southwestern Medical Center, which is in Dallas, Texas. Lesions, for example, could be angiokeratomas, petechiae, purpura, melanosis, and nevi. Dr. Mausker said that if it looks odd, you shouldn't be afraid to go ahead and biopsy. Indeed, in a recent U.S. study that was population-based, researchers evaluated just under 2,000 patients with malignant melanoma of the vulva or the vagina. 1,400 patients had vulvar and 463 patients had vaginal disease. The researchers reported that the median disease-specific survival was 99 months for vulvar melanoma and 19 months for vaginal melanoma. Patients with vaginal melanoma were more likely than patients with vulvar melanoma to have nodular lesions. The researchers found that the American Joint Committee on Cancer Staging System predicts vulvar melanoma outcomes. In addition, lymph node status and mitotic rate were important predictors of survival. Dr. Mausker said that a wide local excision is the mainstay of therapy for melanoma. Other therapeutic advances are changing the survival curves for these patients. This is especially true when you find the lesions early. She went on to say that it is important for dermatologists to include the vulva in skin exams and for gynecologists to have a threshold to biopsy atypical pigmented lesions. Having a very low threshold for biopsy will increase the chances of finding these lesions when they are at the superficial phase, as opposed to the nodular phase. And not all chronic systemic inflammatory diseases are equal enhancers of atherosclerotic cardiovascular disease risk. This is according to a study that was presented at the American Heart Association Scientific Sessions, which of course was held virtually. In the study, researchers included more than 18,000 patients who had one of 6 chronic diseases and about 19,000 matched controls. Every patient received regular outpatient care at Northwestern in Chicago between 2000 and 2019. There were over 1,000 incident coronary heart disease events during a median follow-up of 3.5 years. In a Cox proportional hazards analysis adjusted for demographics, insurance status, hypertensions, etc., for SLE, the hazard ratio for coronary heart disease was 2.8, and for MI, it was 4.7. For systemic sclerosis, hazard ratio for coronary heart disease was 2.1. For MI, it was 3.1. For HIV, hazard ratio for coronary heart disease was 1.3, and for MI, it was 1.6. Rheumatoid arthritis has a hazard ratio for coronary heart disease of 1.2, and for MI, it was 1.4. In an exploratory analysis, the researchers evaluated the risk of incident CHD stratified by disease severity. For lack of standardized disease severity classes, they relied on the tertiles of the CD4T cell count in the HIV group and CRP in the others. The hazard ratio for new onset coronary heart disease in the more than 5,000 patients with psoriasis didn't vary by CRP tertile. However, there was a non-significant trend for greater disease severity as reflected by the CRP tertile to be associated with increased incident heart disease risk in the HIV and the inflammatory bowel disease groups. In contrast, patients with rheumatoid arthritis or systemic sclerosis who were in the top CRP tertile had a significantly greater risk of developing coronary heart disease than the controls. But all 3 tertiles of CRP in patients with SLE were associated with significantly increased coronary heart disease risk. 3.17-fold in the lowest tertile of lupus severity, 5.3-fold in the middle tertile, and 4-fold in the top tertile for inflammation. These findings can be used in clinical practice to fine-tune atherosclerotic cardiovascular disease risk assessment based upon chronic inflammatory disease type and severity. That's information which, in turn, can help guide the timing and intensity of preventative therapy for patients with each specific disease type. And finally today, our COVID-19 update. A hospital-at-home program at Atrium Health, which is in the southeastern portion of the country, expanded its hospital capacity during the early phase of the COVID-19 pandemic by providing hospital-level acute care to COVID-19 patients at home. This is according to a study published in the Annals of Internal Medicine. In the study, researchers evaluated 1,400 patients who received care at the HAH program between March 23rd and May 7th of this year, after having been diagnosed with COVID-19. The program provided home monitoring and hospital-level care in a home-based virtual observation unit, the VOU, and the virtual acute care unit, or the VACU. Patients were tested for the virus at Atrium emergency departments, primary care clinics, urgent care centers, and external testing sites. Those patients who tested positive were invited to be cared for either in the VOU or, if they had mild to moderate symptoms, in the VACU, if they were sick enough to be admitted to the hospital. Nearly all COVID-19 positive patients tested in these sites agreed to be admitted to the hospital at home. Patients with moderate symptoms were glad to be monitored at home. When they got to the point where the nurse supervising their care felt the need to escalate their acute care, they were asked whether they wanted to continue to be cared for at home. The researchers reported that most opted to stay home rather than be admitted to the hospital, where their loved ones couldn't visit them. Low acuity patients in the VOU received daily telemonitoring by a nurse to identify disease progression and escalate care as needed. For those who required more care and were admitted to the VACU, again, that's the virtual acute care unit, a team of paramedics and registered nurses visited the patient's home within 24 hours, setting up a hospital bed, other necessary medical equipment, video conferencing gear, and a remote monitoring kit, which included blood pressure, pulse oximeter, and thermometer. Overall, patients had a median length of stay of 11 days in the virtual OU or the VACU or both. The vast majority, about 1,300 patients, received care in the VOU only. In the cohort, just 40 patients required hospitalization in an Atrium facility physically. 16 of those patients spent time in the ICU, 7 required ventilator support, and 2 died in the hospital. 12% were admitted to the VACU, 21 patients required intravenous fluids, 16 received antibiotics, 40 required inhaler or nebulizer treatments, 41 patients used supplemental oxygen, and 24 were admitted to conventional hospital. Of the latter patients, 10 were admitted to the ICU, 1 required a ventilator, and none died in the hospital. And that's it for the news portion of the show this week. When we come back, peer-to-peer with Dr. Candrice Heath. And welcome back to Dermatology Weekly. I am Nick Andrews. It's time now for peer-to-peer COVID conversations. Please welcome our guest recurring host, Dr. Candrice Heath.
This is Dr. Candrice Heath, your guest host for the Dermatology Weekly podcast. So with us today, we have Dr. Susan Taylor, the Sandra Lazarus Professor of Dermatology at the University of Pennsylvania, where she also serves as Vice Chair for Diversity, Equity, and Inclusion for the Department of Dermatology. And we also have Dr. Lynn McKinley-Grant, who is serving as the President of the Skin of Color Society, and who also is an Associate Professor of Dermatology at Howard University. Thank you so much for joining me today. So today our topic of discussion will be health disparities in dermatology that were brought to the forefront during the pandemic. So this is definitely a hot topic, and we have some great guests, and I look forward to hearing what you have to say. So, what are some examples of the health disparities that have been brought to light during this pandemic? Dr. Taylor?
Well, thank you, Dr. Heath, for that important question. During the pandemic, while we were all quarantined and were able to view the social unrest and the marches around inequalities in the United States, racial, ethnic inequalities, people began to think and really examine the differences and the inequities. And the one that was foremost in our minds was that of COVID. The fact that Black and Brown people disproportionately were affected by COVID and died from COVID. Now, it is a complex situation. I think some of it has been demonstrated to be genetic, but also it's been demonstrated to be related to the jobs, the frontline work that many Black and Brown people have done. So that opens the whole issue of workforce diversity and equity.
Oh, that's good. Did you have more to say? I was going to go to Dr. McKinley-Grant. It looks like you paused.
Yeah, I did. Go ahead.
You have more to say?
I'll come back to it.
Okay. All right. So I'll go to her and then come back to you with this on this topic. Okay.
Yeah. So I'd like to lead into what Dr. Taylor was talking about was the workforce. And I think with the workforce comes the need for public transportation. And that's been a source of early on of COVID and the contact and the close contact on the trains and buses and the needs to actually the Ubers and now the need to do driving. And that's another inequity that has happened. I think also you look at things like food security, getting food, if it's not in your neighborhood, having it delivered, the cost of things has brought out a lot of inequities. I found though, also with the using the telehealth, we've all had to use telehealth. And I saw a huge inequity in terms of just Wi-Fi access, internet access. People are unable to, their phones are just for 10 minutes, an hour, 2 hours. They miss their appointments. They don't have smartphones. It just brought out that the school system now is bringing out the same inequity, but trying to get patients treated with what seemingly was a great idea because it did really increase access in terms of dermatology. You could look at the skin and examine and recommend and send prescriptions, but you do have the issue of people not having internet and another role of access.
I mentioned the workforce and how many Brown and Black people are in the service industry and, had to go to work during COVID and could not quarantine. And that raised for us within dermatology, the ability to look at the workforce in our own specialty. Within dermatology, we know it's been well documented that only 3% of dermatologists are of African descent, as opposed to 13% of the United States population. For the Latinx population, there are 3% dermatologists as compared to 17% of the United States population. So those of us in dermatology and academic centers and in various organizations have begun to examine and think about why is that a truth and what can we do to rectify that? So it has far-reaching implications. Diversity in our dermatology workforce and in all workforces in medicine leads to better care. There's studies that have demonstrated that race-concordant visits, that is where the patient is, let's say, of African descent and the physician is of African descent, those visits, the patient is more satisfied, they tend to be more compliant and get better. We also know that minority dermatologists serve in underserved communities, that they accept public insurance or no insurance at all. They care for patients with particularly poor health status, and are really committed to caring for patients of their own race. So it behooves all of us to examine why this is the case, 3% and 4%, and how we can impact, how we can make a change and increase racial ethnic diversity within the specialty of dermatology.
And, with that backdrop of all of the inequities that were displayed during the pandemic, Dr. Lynn McKinley-Grant, you started to just give us some examples of that. And then do you have any other additional dermatology specific health disparities that you think our listening audience would be able to relate to?
Well, I think a lot of it's interesting that everyone's saying, we've just recognized that there are health disparities in dermatology with COVID, but many of them existed previously. And I think
you're exactly right. I want to just take a full pause there and have Dr. McKinley-Grant repeat that, because there have been people at the forefront of this for decades and decades. But, this is a COVID-related conversation because it seems like, the wool has been removed from the eyes, and now, people can really start to relate to these things. So this is one of the things, more positive things that's come out of the pandemic. It's just a time to really think about these things. So I'm sorry, go ahead, Dr. McKinley-Grant.
No,
I just had to really emphasize that.
Because I had the exact date memorized, but I can tell you it was April 2020 that the health disparities in America were recognized. And so many of those are, in terms of treating patient access to care, where the dermatologists are located, who they are, as Dr. Taylor said, the lack of the workforce diversity. I think people of color prefer to see other doctors who they feel will have the training to deal with their skin. So we have still the health disparity of teaching physicians and medical students about how to diagnose skin in disease in darker skin types. And that's been demonstrated, with COVID also, of people unable to see erythema of the alleged, COVID toes, and erythema of other infections that can occur and are life-threatening. So I think many of the disparities are just accentuated. And the diagnosis of disease is one that is of utmost importance to me, because that's the one that saves lives and decreases morbidity.
And Dr. Taylor, why would you say that health disparities should really matter to all dermatologists? Why is this a topic that all dermatologists should care about?
Well, we don't live in a silo. We all must care about this issue because we're all responsible for the issue, and we're all responsible for the solution. We're part of a whole. The analogy has been made that, we're not 50 states, but we're the United States. So similarly, within dermatology, if we have a problem that's significantly negatively affecting our patients, then it is the responsibility of all of us to change that. And when we are united, then we can affect change. I think that throughout the country, there is an openness now to discuss, to have conversations and dialogue, and look towards solutions. I'm very proud of our major organizations, be it the American Academy of Dermatology, the Women's Derm Society, the Society of Investigational Diseases, the Investigational Dermatology, the Association of Professors in Dermatology, and the Skin and Color Society that's been doing this work for 20 years. Everyone is really rising to the occasion and making concerted, great efforts to change these disparities.
And Dr. McKinley-Grant, what kind of charge would you give to all dermatologists that can really rally them around this topic of health disparities?
So the charge would come in terms of really treating all patients equally and getting the training to give quality care to all patients. I think also right now we're in the season of looking at and accepting for training new dermatologists. And so I think there's a responsibility on the academic side to really look at the diversity of the applicants and the quality, the high quality that they're going to be seeing, and then to be able to accept those applicants into dermatology. It is an inclusive specialty, and I think every program will benefit from training more. I think in terms of the dermatologists in practice, I found during COVID, when offices had to be closed, it was very, very stressful for dermatologists of color who were in practice, and they I just had not seen the level of depression and still, because everyone loves dermatology. There's a passion of dermatologists who practice, and we just have a passion for the treatment. So I would also encourage doctors just to be, more open, to increase access. And saying that, you have to really look at, insurances too, and what insurance you're accepting, because that will increase access also to dermatology. And the important thing is about educating and then also mentoring, as other dermatologists, residents or younger dermatologists or younger medical students, to do the mentoring to get people into dermatology, or to focus on the skin as a major vital organ.
And Dr. McKinley-Grant, I know that you are currently the president of the Skin of Color Society, and ironically, well, not so ironically, we also have Dr. Susan Taylor, who founded the Skin of Color Society. But since you're the current president of the Skin of Color Society, I know that when you were elected to your current office, I'm sure that preparing for a pandemic was not on your radar at all. But how have you been able to use your leadership platform to just begin to start to tackle some of these disparities in dermatology?
Well, I think you're absolutely right. This was not on the radar screen at all, and I think even the vision of the role that I've been playing was not on the screen at all. It's been very eye-opening, where people are recognizing this need for more diversity in dermatology, and they're coming to us. This is a source. You guys have done a great job with the mentoring, with research, with just education. And so there's been a lot of funding. I won't say a lot, but there has been an increase in funding. with the diversity, when we're calling it the Diversity Fund now, so I think we've been able to do more, and we continue to be more visible, and we're doing a series now with the New England Journal of Medicine group, and that has been very successful. We've been able to have a lot of leaders who have done a lot of research, a lot of work, and it's been a very way to get the word out about skin of color and pigmented skin. So it's kind of like we have a base for people to come to get education and to increase research and for the mentoring. And we'll continue to do that.
I am tremendously proud of the work, the around-the-clock work that Dr. McKinley-Grant has been doing for the past year on behalf of the Skin of Color Society. I'm sure there was no way for her to anticipate or prepare for the pandemic, but she has really taken this organization to levels and heights that I had not dreamed of when I first started it. When you look at the degree of funding that has been increased for research related to skin of color issues, that has increased exponentially under Dr. McKinley-Grant's leadership. There's now a significant $100,000 career grant that's offered in addition to the other grants. When we think about exposure and education of the dermatology as well as the whole medical community and lay people, that has taken off exponentially with this series in conjunction with the New England Journal of Medicine. There are other huge initiatives that she's not announced yet that the society, the Skin of Color Society, is involved in, again, around education. The mentorship program has been increased. So all of this has been under her watch, and it has taken this society to completely new levels. And I want to thank her, and we all have a debt of gratitude to her, not to mention the collaboration with Cutis and MD Edge, which we're a part of today. So thank you very much, Dr. McKinley-Grant.
Well, thank you. And I have to thank, this has not been a job done alone. I have to thank Dr. Heath also, and to thank you, Susan, actually, too, for guidance and just being there and even starting the society. But we have an amazing team of co-chairs of different committees, and everyone is putting in such great efforts. It is and great efforts at reaching out to other societies and other groups and bringing, the SNMA, the NMA, we're all working together, and it's a very, the AAD, I mean, they're just these little fingers that are out there and pulling everyone in to address the issue of skin of color. So, but thank you for those comments.
Yes, I think those were definitely comments and accolades that are definitely well placed with Dr. McKinley-Grant and everything that's going on with the Skin of Color Society. So I thank you again for that. And I hope that, I imagine in my mind, that all of the early supporters of the Skin of Color Society, like Cutis, MD Edge, who's now under the umbrella of Medscape, that they should be sticking their chests out to say, we were supporters from the beginning, early on.
Yes.
So I hope that we can, give them that distinction as well. But we also welcome the new supporters. But, I definitely want to get back to Dr. Taylor on this question about using your current leadership roles that you have during the pandemic to really start to tackle some of these issues.
Well, I am just absolutely delighted to report that the American Academy of Dermatology, which is our largest organization for dermatologists and for our patients, has been at the forefront in instituting change. And I am currently the vice president of the American Academy of Dermatology. So some of the initiatives that have started include a curriculum, a skin of color curriculum for dermatology residents. As many people know, there is, for many programs, a paucity of training related to skin of color. At some programs, residents may not see people with skin of color. So we have, over the last 6 months, created a committee, and Dr. Heath is on the committee, Dr. McKinley-Grant is on the committee, and we have developed modules that the residents will have access to. We anticipate initially between 60 and 100. They include topics on skin of color, inpatient, outpatient, surgery, pediatrics, cultural competency. So this is really under the auspices of the American Academy of Dermatology. We have created a committee, a work group of the Academy that's looking at how to instruct our members to better take photographs of skin of color, how to create a photo bank of photographs for skin of color. The Diversity Committee of the American Academy of Dermatology has just passed multiple initiatives to increase the pipeline in dermatology to support several programs, not only the AAD Diversity Mentorship Program, but the Nth Dimension Program, to bring along that next generation of diverse trainees to enter the field of dermatology. So those are just a few of the initiatives of the Academy around diversity. And I am just absolutely thrilled with it. Let me just also point out that the Academy has partnered with the Skin of Color Society, the Association of Professors in Dermatology, the Women's Derm Society, the Derm section of the NMA. So this is also, many of these efforts are collective efforts, going out to the SNMA and the NNMA to talk to young people, get them interested in dermatology. So, I think that what COVID has done is it's allowed an atmosphere and an environment of openness and of wanting to participate in solving these problems.
And, we have a very wide listening audience, and this is what I love about dermatology. So we have colleagues who are in private practice. We have colleagues who are in academics. And then of course, we also have our dermatology residents who are also rising through the ranks to become dermatologists. So in each of those areas, there are some unique opportunities to really make an impact on health disparities. And I'll start with Dr. McKinley-Grant, just thinking about things that you could advise some or all of these groups using their unique positions to make an impact on health disparities in dermatology.
So the group I'll kind of start with, because I think they're on my mind a lot, are the residents. And I think training them in terms of ways of thinking and giving them as much exposure to patients of color, creating opportunities for them to do observerships or go to if they're in an area where there aren't many people of color in their particular area, to get that experience early while they're in training, because I think it's very important. Also, at other levels, in terms of dermatologists and faculty, getting people more into accepted into dermatology. And I think the ideal programs have been these diversity positions that have been created at 2 programs only now, Duke and at University of Pennsylvania, to work on getting residents. These types of programs improves the number of residents that are attracted, people of color who are attracted to the programs, but also encourages the curriculum to change too. So I think for getting more training and then being able to bring in more people who are interested in the skin of color into residency programs.
And Dr. Taylor, do you have any other ideas and things that can be that the other groups can do, like private practice, or there was in academics?
Yes, so Dr. Heath, now I'm in academics, but for 27 years, I was in private practice. And what I found very helpful was to create mentorship opportunities for college students as well as medical students, where they would come and spend various periods of time with me in my office. They would shadow me, so they would have an opportunity to observe patient care. They would shadow me when I saw research patients, but also I would spend time talking to the college student or the medical student and answering all of their questions and exposing them to dermatology. So if you're in a private practice, you can most definitely mentor young people, and that can go very, very far. Additionally, I think it's important for private practice physicians to understand that they can impact in multiple ways. So perhaps you don't have the time to mentor individual students. Well, it could be very impactful to donate money to the different organizations that have mentorship programs, whether it's Skin of Color Society, whether it's Women's Derm Society, whether it's the AAD. You can earmark your funds for mentorship programs. And that is incredibly important and incredibly impactful, because then the organizations can reach more students. So there are many, many ways of skinning a cat. Do you have a couple of interesting cases that could be written up into case series or case reports? That's a perfect opportunity for a student, a medical student, to build their publication portfolio. So individuals in private practice don't get a pass. You can make just as significant an impact as those in academics.
And Dr. McKinley-Grant, do you have anything to add to that?
I would add, and I'm going to put this on Dr. Taylor a lot. She has done an incredible, amazing job of mentoring, and not just mentoring, it's getting people to success. I mean, they've gone from student, they've published, I'm sure it's helped with her publications too. They go on to residency, they become, whoever they are. I don't know if you have any chairs yet of departments, but there is an effort, and I can't imagine where she even has the time to do this, but it is a definite priority. She's used her own funds for fellows for a year, to pay for a fellowship for a year. It is definitely the way. And one of the things that we don't get as particularly African-American, I'll say in my experience, but we don't early on get that kind of mentoringship. In medical school, you may not be the one chosen to work with Dr. So-and-so to write. He may not ask you to write the paper, but I think we are here, we want to help. I think Dr. Taylor has been the model of this, and we have to keep putting it out how, I think mentioning the mentorship, and if you don't have time to mentor, you can pay for a mentorship. I think these are solutions. We want to look at what are some of the solutions. And I think she's come up with many, and I really appreciate that too.
Thank you. Thank you very much.
And as we close this COVID conversation on health disparities in dermatology, I definitely would like to give both of you the opportunity to just give some closing remarks. So I'll start with Dr. Taylor, and then I'll end with Dr. McKinley-Grant.
So disparities in healthcare and in dermatology are an important issue for all of us, whether you are of a diverse background or not. It's going to ultimately, commitment to these issues improve patient care. They improve the lives of people. And I think that if you are not sure what you can do, call me, email me, Dr. Susan.Taylor@pennmedicine.upenn.edu. If you want to do something, you don't know what it is, I can plug you in. It takes an effort of all of us to make a difference.
And Dr. McKinley-Grant, closing remarks?
So I will just say I'm going to try to end optimistically too about COVID. It sounds like, with the vaccine, we're on the, things may turn around. It might be a year, but at least there's a little bit of hope there. And it's a time, if we are going to be inward and inside and, not with people as much, there's still a lot that can be done while you're inside. You may not be out, but you can still make a lot of change. And I think it will be a time that we can come together. We can provide opportunities for people of color to want to go into, who want to do some academic work. It may be an opportune time. So I think efforts to change health disparities can be made during this, and I'll call it an inward time of COVID.
Well, I would like to thank both of you for joining me today, both Dr. Taylor and Dr. McKinley-Grant, for joining me on the podcast for another COVID-related conversation. And this time it was on health disparities. And for the listening audience, you already know who I am, but this is guest host, Dr. Candrice Heath, your favorite fun board-certified dermatologist, your go-to girl for everything healthy hair, skin, and nails. And thank you for joining me for a series I call COVID Conversations with Dr. Candrice. See you next time.
And that's a wrap on this episode of Dermatology Weekly. I am Nick Andrews. Dermatology Weekly is produced by MD Edge editors Elizabeth Meshkati, Melissa Sears, and Alicia Sunners. All of our podcasts are produced by executive editor Kathy Skarbeck. Social media is produced by Kyla Clark. I am your audio editor, audio engineer, and the host of the news portion of this show, Nick Andrews.